Hello everyone. Today we will be talking about a very important topic to keep our elderly population safe in healthcare. It is about depression, dementia, and delirium. This topic may just not be well understood enough because we have evidence that many of our elderly folks do not get diagnosed properly, and because of the signs and symptoms being sometimes confusing and because they overlap, the diagnosis of those three diseases may be a challenge. We cannot treat unless we understand the clear diagnosis of our patient. Delirium may just be the one that we need to focus a little bit more on because if not treated, it can actually lead to death. And that is according to Harris. In 2017, he published his article saying that the consequences of delirium can be prolonged hospitalization, also decreased functionality of the older adult, but also mortality. He explains that there are three basic presentations or subtypes of delirium, and one of them is the hyperactive delirium, and then we have the hypoactive, and we also have a mixed subtype. Now, he points out that healthcare providers usually have a pretty good eye when it comes to detecting the hyperactive delirium because the person is so agitated, and that is different from a depressed folk or even from a dementia patient. But in cases when the subtype presented is hypoactive, somnolence is actually the typical presentation, and a lot of times it just goes undiagnosed. He says that the mixed subtype is also underdiagnosed, and that one comes with a mixture of some agitation and some somnolence. According to this study, delirium occurs in 1 out of 5 hospitalized older adults, and neurology units get hit the hardest with this kind of syndrome or presentation. And it makes it even more challenging to detect or differentiate between dementia and delirium because 32% of our cases are superimposed on dementia. So dementia patients also have a predisposition even higher than others to have delirium. And the problem is that if we don't understand the signs and symptoms and also the baseline of our patients well enough, we may just not realize that our demented patient is experiencing delirium because of an underlying cause. And not understanding that may just mean that we don't treat the underlying cause, which can kill our patient. Now let's just talk a little bit about dementia. The most common cause of dementia is damage or injury to the brain. It has to do with some neuritic plaques that are formed when a protein called beta amyloid clumps together and doesn't allow the neurons to grow and repair. There's another problem involving microtubules in the brain, specifically in Alzheimer's disease, and that affects the capability that neurons have to transport information. Now, Alzheimer's disease is the most common cause of dementia, but there are other pathologies that also cause dementia. There is frontotemporal dementia, there is vascular dementia, Lewy body dementia, Creutzfeldt-Jakob disease, Wernicke's encephalopathy, and Parkinson's disease, and even things like AIDS and trauma can cause dementia as well. Now, before talking about assessment tools, let's just talk a little bit about depression. Eliopoulos says that about 20% of our elderly population has depression. And that estimate goes up when we're talking about long-term care residents. Maybe symptoms like insomnia, hopelessness, and helplessness are easily seen and attributed to depression. But it's important to also consider symptoms like apathy, self-deprecation, guilt, and feelings of being a burden. Some of these things we'll only find out with a good psychosocial assessment. Well, there are 3 assessment tools that I would like to highlight. The first one is the Mini Mental State Exam, also called MMSE. It is an 11-question tool and it tests 5 areas of cognitive function. It tests orientation, registration, attention and calculation, recall, and language. It takes about 10 minutes to do the MMSE, and all we'll find out is that the patient has one of those 3 Ds: delirium, depression, or dementia. Now, we're yet to find out which one of the 3 the patient has. If it's looking more like our patient may be experiencing delirium, for example, we know that the onset was very sudden, maybe hours to maximum days. Or we know that the patient is not oriented. Dementia patients are usually oriented. Maybe we notice that the patient is, the thought process is incoherent. And it's looking more like a delirium case. So we already spent about 10 minutes identifying that the patient indeed has some kind of cognitive impairment. And now we're going to go straight and try to either rule out or rule in delirium. All right, so we're going to use the confusion assessment method, also called CAM or CAM. CAM is composed of 2 parts, and the first part just establishes that the patient has some kind of impairment in their cognition. Since we already have that established, we can go ahead and apply the second part, which focuses on 4 questions, and it assesses the fluctuating course of the abnormal behavior that we're noticing. Then it also addresses the inattention, the disorganized thinking, and the altered level of consciousness. It only takes about 2 minutes to do that assessment. So if this is the case and we ruled in delirium, with about 12 minutes spent on that patient, we now have a very good knowledge base about the diagnosis of that patient and can therefore start finding the underlying causes of the delirium. Of course, all that will be relayed to the provider, and the provider will then be able to join in and then diagnose the underlying cause, and it'll be 12 minutes spent by the nurse to help and provide very valuable information to the provider. And of course, I am not saying that this is the job of the nurse to do, but the nurse can use these tools as well. Now, the provider treating the patient should have knowledge of these tools and should do this kind of assessment using the mini-mental state exam to determine some kind of impairment, and then trying to rule out either delirium or dementia to arrive at depression, or to rule out depression and delirium and arrive at dementia. Now, the tool that I want to highlight for depression is called the Geriatric Depression Scale, or GDS, and it is a series of 15 yes or no questions, and it only takes about 7 minutes. So if the symptoms of your patient are lining up more with a depressive scenario, then after doing the MMSE, or mini mental state exam, you would go and use the GDS, Geriatric Depression Scale. If the patient scores 5 or more out of the 15 questions, because they get 1 point for each yes, they would then be treated for depression, and a plan of care could be started around that diagnosis. Now back to Heliopolis, the plan of care for depression in the elderly population will be much like the plan of care for depression in younger populations. They will be treated with medication and psychotherapy, hopefully both. Um, the main medications used are serotonin, um, selective serotonin reuptake inhibitors, or SSRIs, cyclic compounds, or monoamine oxidase inhibitors. But the provider should note that since we are prescribing that to an elderly person, the starting dose should be about half of that of a normal adult. Wow, that didn't sound right. Like the average adult, I should have said. So, even though, like Mendes puts it, the process of identifying whether our patient has delirium, depression, or dementia is a confusing one, we now have a better understanding of how to go about it. And to recap, it's important to always know what's usual for the patient so we can know the baseline. And remembering that if the baseline is dementia, we should not automatically rule out delirium because they can have both. And the source of information can be the patient themselves, but it can also be family members or caregivers. This video was presented to you by Aurelio Zabaleta, and here are the sources that I used.